fantastic start in 2022. So welcome to our first monthly meeting of this year. So today we have an interesting presentation from Aster Medicity, Dr. Unnikrishnan Ji, Clinical Associate Professor, Multi-Organ Transplant Surgery Unit of Amrita Institute of Medical Science, will be moderating today. So Dr. AML won't be coming today. So instead, Dr. Pidambaran will be presenting the quiz. As usual, we start with the quiz, followed by the main topic. So I request Dr. Unni to take over the proceedings. Thank you.
Thank you, Dr. Raman. Let us not waste any time. We are already running behind by 10 minutes. Pidambara, would you mind running the quiz first and then we will proceed?
Yeah. Hope you can see my screen.
Yes.
Hello.
Yes.
Yes.
Okay. So this is the. I'm not going to the bigger question. There is just one spotter. One slide will be shown, and the this is a slide, and the question is identify the procedures.
Can you
The
make
answer-
it wider screen? Screen
One
full
minute.
size.
Full screen, Akao.
Full size.
One minute. Full screen. Full screen on actually.
No.
ഫുൾ സ്ക്രീൻ ആണ്. കുറച്ചുകൂടി വലുതാക്കണമെങ്കിൽ
Yes.
Okay.
Much better.
The answer should be sent as a personal message in the chat box. Everyone can answer. I think everyone should give a try at least. I think we can go back and we'll have the case presentation and we'll discuss the answer later.
Can I invite Dr. Ashna Espal from Aster Medicity to start the presentation?
Stop share. Okay.
Good evening, sirs. Is my screen visible, sir?
Yeah.
Okay. A very good evening to one and all. Myself, Ashna, DNB resident from Aster Medicity, Kochi. Today, I'll be discussing a few unforeseen challenges that we faced in choosing the perfect timing for surgery in a case of a liver tumor. Our patient is a 63-year-old gentleman who is a retired police officer. He is under medical treatment for diabetes, hypertension, and dyslipidemia. He came to our OPD with complaints of excessive fatigueness of past 2 weeks duration. As per the patient's own words, he was unable to carry himself and get to do with his day-to-day activities. There was also associated upper abdominal, especially central abdominal pain of 2 weeks duration, which was dull aching and with occasional radiation to back. He had extreme loss of appetite and sleep, and he had also significant recent weight loss, but it was not quantified. There was no history of any fever, vomiting, jaundice, hematemesis, melena, or any alteration of his bowel habits. He came to our OPD after 2 weeks of onset of symptom after evaluation from another center. At admission, his vitals were stable, he was febrile, there was no pallor or icterus. His performance status was ECOG of 3, BMI was 20. Abdominal examination was unremarkable except for mild tenderness in the epigastrium and a palpable liver of 16 centimeters. His routine lab investigations revealed elevated counts of 16,000 and a low albumin of 2.6. The rest all were within normal limits. He brought with him the CT that was taken from the other center, which showed a lesion measuring 6 to 7 centimeters involving segment 8 of liver and another satellite lesion in segment 7. The lesions were not characteristic of any particular diagnosis as far as the radiological discussion was concerned, and it also showed a mildly edematous pancreas. He also brought with him an MRI which was done from the other center, which was also inconclusive of a definitive diagnosis. So we went ahead with an alpha-fetoprotein, which was within normal limits. So we had a patient with no background cirrhosis, with normal IFP, and with a liver lesion. Our prime DDs were either an HCC or an intrahepatic cholangiocarcinoma. To arrive at a definitive diagnosis, we went ahead with an ultrasound-guided biopsy, not only from the lesion, but also from the normal liver. The lesion was reported within a few days to be a well-differentiated HCC, which was IHC positive for glypican-3. And the normal liver showed features of early fatty changes, with mild steatosis and mild portal and lobular inflammation and fibrosis. So since he came with a CT which was done a few weeks back, we thought of repeating the CT to plan upon the treatment options. The CT in our center showed that now the biopsy proven HCC was involving segment 8, and it was lying in between the right hepatic vein and the middle hepatic vein with involvement of the MHV. And there was a satellite lesion in segment 7 as well. And a focal tumor rupture, suspicious tumor rupture was seen in the superior aspect, but there was no free fluid. So basically we had an HCC involving segment 7-8, no background cirrhosis, normal AFP. Our prima facie, we thought of going ahead with an extended right hepatectomy. So to assess the volumetry, we did a baseline volumetric evaluation and showed that the left lobe, that is the FLR without the MHP, was 30.5. That is a normal, that is a lower borderline acceptable value. But what took us by surprise was the presence of extensive necrotizing pancreatitis with multiple fluid collections. And this was the exact reason for his pain, poor appetite, and his poor performance status. So this wasn't a real surprise for us because his initial evaluation showed a normal amylase lipase levels. So at this juncture, we were facing 3 main challenges. One is, of course, the poor performance status of the patient, the acute necrotizing pancreatitis, and of course, the HCC with the marginal low volumetry issue. So at this point, an MDT was called upon involving the medical gastro, the surgical team, the interventional radiologist, as well as a medical onco team. Our prime concern was to buy some time to tackle the episode of acute pancreatitis. So a consensus was reached to consider the option of TACE or TARE followed by portal vein embolization. The options were given to the patient, but they were undecided. They were discharged at request, and they said they'll come back after making a decision. They came back after 3 weeks with persistent symptoms, even worse appetite, and so we were forced to take a repeat CT, which showed that the lesion in the liver was remaining stable, but the pancreatitis had now evolved into a walled-off collection with multiple air pockets. We repeated his labs, counts were still high, albumin was still low, and his performance status was poor with poor oral intake. We had to hydrate him with fluids, started him on antibiotics, and we stressed upon them to take a decision upon TACE bar TARE followed by portal vein embolization. Their main concern with TARE was the financial issues, and so they decided to go ahead with TACE. TACE was performed in the mid of 6th week with selective cannulation of the tumor feeding vessels, and doxorubicin 50 mg and 8 ml of epidural was infused. And post-TACE final angiogram showed good staining of the tumor. Labs were repeated, which were within acceptable ranges, and he got discharged after 4 days. He was called for review after 4 weeks. Meanwhile, his general condition improved, his performance status became better, he was asymptomatic, and he had good appetite. So we repeated the CT to assess the response to TACE and to assess the status of pancreatitis. We found that the satellite lesion in segment 7 had disappeared completely. There was residual tumor in segment 8, which was showing partial response as per the MRESIS criteria. And the pancreatitis luckily had resolved, although there were few residual collections, but patient was asymptomatic now. So at this juncture, we had HCC confined to segment 8, post-TACE with partial response and with resolving pancreatitis. We went ahead and reconsidered our initial plan of going ahead with an external right hepatectomy. This is a tumor which can easily be cleared by a central hepatectomy, so that will tackle the volumetric concern as well. So we didn't go ahead with the portal vein embolization. We planned to go ahead with surgery. So he was still ASA4, pre-op HB was 7.9, but his performance status was ECOG was 1. He got pre-op cardiac and pulmonary clearance, and he was taken up for central hepatectomy on 25th of September. In ROP, it was a large SCC arising from segment 8. There was no visible lesion, obvious lesion segment 7. The main MHU was involved, which was obvious, of course, resected. His post-op recovery was uneventful, and he got discharged on day 7. He came for a review after 2 weeks. Meanwhile, the final histopathology had confirmed it to be a poor to moderate differentiated CC with necrosis as evidence due to the TACE and with negative margins. It was a T2 N0 disease. He was on follow-up after 1 month. His LFT was normal, and we went ahead with ultrasound, which was normal except for right minimal pleural effusion. So to highlight, what we would like to know is that the timeline of the patient. As soon as the patient developed abdominal pain, he went to a nearest center where a CT was taken within 2 days of onset of symptoms, which picked up the HCC. He came to us after 3 weeks. Meanwhile, the pancreatitis had evolved into a necrotizing form, and the tumor was also there. In 6 weeks, it evolved into a walled-off necrosis with air pockets. So we needed time to tide over the situation, and which was tackled with a TACE, which was performed in the mid of 6th week. By 10th week, the tumor showed response, partial response to TACE, and meanwhile, the pancreatitis had also settled. So by the mid of 10th week, we could go ahead with central hepatectomy. So the point that we would like to convey is that with meticulous planning and timely utilization of resources, we were able to tackle with the situation that was totally unexpected in this case of a central hepatic tumor. Thank you.
Can I open the discussion?
Yes, please.
Just a question. Did you do a PIVCA at any point?
No, sir, we didn't do a PIVCA.
Oh, just that is an institutional thing. Some people do, some people don't. And during surgery, was the segment 7 area addressed, or was it just left because CT had shown complete response?
CT had shown complete response, and intra no lesion was palpable, so we just left it alone.
Did you do an intra-op ultrasound?
We didn't do an intra-op ultrasound because the satellite lesion segment 7 was actually 2 centimeter in size pre-op CT. So we expect the TACE to give a complete response to that lesions.
Okay. Can I get opinion from other centers regarding their view on that? Shabir, Ramendran? Dr.
Hey,
Prakash?
Ashna, hi, Ashna. I'm Ramchandran.
Yes, hello, sir.
Hi. Excellent case, and you have presented it very well. A couple of doubts. One, what do you think the cause for acute necrotizing pancreatitis? That is my first question. And second, have you done any PET CT, PET scan? Third, what was done for that infected pancreatic necrosis. How do you treat that? What antibiotic was given? Was it a FNAB, fine needle aspiration bacteriology proven infected pancreatic necrosis, or any other reason for that air pockets?
Sir, about the PET scan,
Sorry. Yeah.
we didn't go ahead with the PET scan initially because we were not expecting a metastatic disease. That is one thing. Patient was asymptomatic otherwise. And CT, we had taken CT chest cuts. We didn't show any obvious lung lesions.
But it was a
Then,
multi-center HCC, no? There were
yes,
2 lesions.
2 lesions were there. Okay. About the cause of pancreatitis, actually the patient was not an alcoholic. He had stopped alcoholism way back, some 10-20 years back. And there were no obvious gallstones seen. So it could be microlithiasis. We are not sure about the etiology of pancreatitis.
Did you remove the gallbladder?
Yes, sir. Yes, it was remotely dropped.
And what antibiotic was given? How did you treat the necrotizing pancreatitis?
There was only CT evidence of air pocket. Patient didn't have any fever. The counts were only marginally elevated. So we started him on empirical antibiotic. So not culture proof.
Okay. And how was it like intraor with the pancreatic area?
Pancreatic area was inflamed and edematous. So we didn't meddle with that.
There was a suspicion of a rupture initially. Was that there intraoperatively?
No, sir, there were no obvious tumor rupture because even CT also there was no free fluid as such. It was just seen abutting the diaphragm, that's all.
Can I? Hello.
Yes,
Yes, Shabir, you can hear you.
Yeah. Ashna, it was an excellent presentation. Yeah, it is a very tough case to manage. My thoughts also were somewhere similar to Rabendran's. Can you correlate this tumor with the pancreatitis? Can this tumor anyway be related to the pancreatitis etiology?
So literature shows that if the tumor is involving or encroaching upon the bile duct, it can cause tumor embolism into the bile duct and cause pancreatitis. But as imaging findings, there was no obvious features of bile duct infiltration as such.
Okay, you can get biliary emboli and pancreatitis from that. Yeah, that is one thing by which you can correlate in a remote possibility.
Yes, sir.
Okay. And this another concern was it had extensive wear, I think, in the necrosis. And it was managed with antibiotics and it settled with antibiotics.
Yes,
Any
sir.
follow-up of that pancreatic necrosis?
We did follow-up ultrasound only, sir. Post-op follow-up ultrasound was done, which was no residual collection, nothing, sir.
Okay,
it was actually the first episode of pancreatitis, in fact.
If you have an infected pancreatic necrosis on board, would you consider what are the issues related to a major hepatectomy? Why you choose?
The
Why you
initial
have chosen?
phase was planned. So
Hello?
whether if hello, Shabir, you want to continue?
Yeah. What are the why you have gone for a central hepatectomy instead of an extended hepatectomy that time? Because initially you planned an extended right hepatectomy, I think.
Because initially it was multifocal in the form of segment 7 and 8 involvement. We can't get ahead with the central hepatectomy in that case. But following days, since the 2 centimeter lesion in the segment 7 had resolved completely, we went ahead with the central hepatectomy.
Ashna, I don't think
what
that
are
is
your
right
concerns?
because-
What are your concerns related to a major hepatectomy when there is an onboard sepsis?
High risk of post hepatectomy liver failure.
Yeah, when your liver reserve, for a normal person, it is like 25 or 30%. But when you have a sepsis and patient is catabolic, everybody would be a bit concerned about doing a major hepatectomy because then the reserve will be more and the normal remnant may not be sufficient.
Yes, sir.
Okay. That may be one reason you have gone for a conservative approach.
Yeah, can I clarify that? Because when the patient came initially, the patient's performance status, everything was very poor. He never appeared to be a patient who can come up for a major hepatectomy. So our main option what we were given was the tear to them at the initial point of view. And this necrotizing pancreatitis, even though he had no features of sepsis, this was always in the background. In the post-op period, if he develops necrosis and sepsis, so how would we manage that? That's why we wanted to wait. Actually, in the waiting period, the TACE was the only option the relatives could afford for, and they asked for. But we got an excellent response with that. And while waiting, luckily the pancreatitis also settled down without any major intervention. So we went ahead with the more conservative plan. Of course, PET scan was one point which was valid, which we could have thought of. But actively, the plan for surgery came in only after the TACE. In fact, if before that, they were also not very keen for surgery, and a major procedure was not actively contemplated because of his poor health status and pancreatic necrosis.
Can I ask one?
Yeah, sure. Go ahead.
So, Ashna, you have mentioned that that segment, the small lesion in the segment 7 disappeared after TACE.
Yes, sir.
Yeah. So it can happen, but it is a multicentric HCC. So you will be embolizing the right hepatic artery, or which artery did you embolize? The
Segmental arteries were only embolized.
Segmental artery. So segment 8 and then segment 7, because these are in two separate segments. So you did see you embolized 7 and 8 separately.
Superselective
of both vessels.
Sorry, sir.
See, segment 7, it's getting its supply from segment 7 artery. 8 is from anterior artery, anterior segmental branch. So we have embolized both these suprasegmental branches, which is
I talked with the radiologist. They have specifically, because they had also noticed that lesion pre-op, segment 7 separate lesion pre-op. So they were keen on superselectively cannulating and embolizing both separately.
Very nice. And second thing, even if you embolize TACE, it won't usually disappear completely. So if you are planning for a resection with curative intent, ideally you should take that segment. Unlike microwave ablation in a small lesion. So TACE won't completely ablate the tumor usually.
Can I add on to that? That is why I initially asked whether an intra-op ultrasound was done. Now you have an area of liver that had a tumor previously, that had a TACE fully done, which will need probably lifelong follow-up for that. He'll anyway require lifelong follow-up for the HCC, but that area is going to be worrisome. Personally, I would have gone for an intra-op ultrasound, and if there was anything suspicious there, call the radiologist into theater and burn that suspicious area off. Does anyone have any opinion on that?
But if it's a small HCC, the response to the TACE is quite equivalent to any other procedure, no, for a lesion less than 2 centimeters.
Sub 2 centimeters, I agree.
Yeah, why can't we think about that? Because it hasn't responded fully. So would you want to really target a disappearing or disappeared lesion? That's our point of view.
The problem is now you have a poorly differentiated HCC post-operatively on the histopathology and ablated a TACE area alone. Like I said, I mean, it's a personal thing. I would personally do an intra-op ultrasound. And if there is any suspicious area on the IOUs, I'll get that area microwaved on table.
Can I ask one question to
sure.
Ashna? Ashna, a very good case. Actually, I just want to know what are the evidence do you have? A presentation of HCC with pancreatitis. Have you searched any case report or anything like that? Second question is when there is a necrosis, percutaneous drain could have been placed, or even if it after 6 weeks, if you find a persistent necrotic area, would you have done a percutaneous drainage or something, pigtail in that?
Sir, about the first question, yes, sir, I searched literature and there were case reports where HCC was actually the first presentation was as acute pancreatitis, but in those cases they were able to demonstrate the presence of a biliary thrombus due to a tumor fistulizing into the biliary tree. And regarding the second question, sir,
Percutaneous drainage.
yes, sir, percutaneous drainage, but as of we are planning for a step-up approach. If the patient was deteriorating, we could have gone ahead with a step-up approach. But then since the patient responded to empirical antibiotics, we thought of waiting, sir.
Are there any further questions?
Ashna, one more thing. It's a theoretical question. When you have a big tumor with a suspected satellitosis, would you do further imaging, any other imaging, or are you happy with CT scan?
We can do MRI can be done, sir, because it can even pick up even smaller lesions. This patient already come with an MRI from the other center. It showed the same findings, sir. That is why we didn't go.
Okay, there were MR was already done.
MR
Yeah,
was
just
already
theoretical.
Yes, sir.
For your exam purpose, I asked. Because MR always picks up more lesions in such tumors.
Yes, sir.
Ashna,
Sir?
you are contemplating a phase in the presence of initial phase in the presence of necrotizing pancreatitis. So whether actually the waiting of 3 weeks, the patient went against medical advice and came back actually was good for the patient or not?
It turned out to be good for the patient, sir.
No, whether retrospectively that it turned out to be good for the patient, and what will be your take home or opinion on regarding that? Whether we should have done that at that time or we should have waited that, because that's a question. The topic itself mentioning timing.
Sir, but when he went home, he didn't have these air pockets or walled off necrosis, just fluid collections alone were there. Could be sterile as well at that time. So TACE would have been easier at that time. And we could have operated him even maybe 3 weeks earlier.
Can I make a comment on that?
Yes.
Now that everything went well, everybody is happy. If we gave a test of biology for the necrotizing pancreatitis and the patient failed the test of biology on the tumor, it would become a difficult situation dealing with that and discussing it with the patient.
Yes.
So I'm not sure that without a evidence of infected necrosis, waiting 3 weeks on that would have been a practical option. I'm not sure that there would be any science to discuss this.
No, I'm not telling about the science, but
yeah, exactly. That is what I said. There wouldn't be much science, but if the tumor progresses to 4 satellites while you tell them to wait for 4 weeks, it will become difficult to, discuss it with the patient and tell them that you are on a palliative line.
No, actually it was not palliative. Actually, the correct plan was TACE followed by portal vein embolization extended hepatectomy. That is the original plan.
Yeah.
But patient came later, and when we assessed there was adequate response, so the portal vein embolization plan was taken off. That has actually happened.
So is there a possibility that now there is a tumor recurrence on the residual right lobe, and we can do the remaining right hepatectomy later? Because by the time the other lobe will be hypertrophic also.
No, I don't think personally that small lesion is going to recur that soon, because it's a small lesion. Why can't we take it as a small lesion? That's my argument is. See, the results for surgery, RFA, microwave, and TACE are all equal for sub 3 centimeter lesions. That's well proven in the literature. So is there any major difference by doing TACE and observing if the lesion has adequately responded? This is my point of view.
Dr. Prakash, again, not a science question or query. Most of the TACE, no interventional management of hepatocellular malignancies, progressed dramatically because of the morbidity of surgery on the liver. If you are anyway inside the abdomen, there is no added morbidity to dealing with segment 7 is all my point.
That I agree.
Ashna, a couple more questions.
You have the biopsy report. Did you look for any biliary invasion or anything in biopsy?
Biopsy, they checked for it, but there were no evidence of biliary invasion.
What about the tumor? Was there any residual tumor?
Yes, sir. It showed only 50% necrosis. That is a segment 8 lesion. Rest was residual tumors.
So, have you done any upper GI endoscopy before surgery? Endoscopy?
We didn't go ahead, sir, because we are not expecting there was no features of cirrhosis for the patients.
Platelet, everything was fine.
Everything was fine.
Even at the time of even at the time of initial presentation.
Yes, sir. Yes, sir.
And have you checked for any hypercalcemia or any paraneoplastic syndrome?
Triglyceridemia, hypercalcemia evaluated all at the normal levels.
What is this satellitosis? Raj, I've not heard it before. Satellitosis. Hello.
Yeah. What is that, Ashna?
The pathology that they reported, sir, satellitosis.
What is it? Satellite nodules or metastasis or steatosis? What is it?
Actually, I didn't look it up, sir. I believe it is the satellite nodule within that tumors, within the specimens.
Within this specimen. And Prakash, how do you know that there is no leftover tumor in segment 7? Because local treatment is not curative. Maybe supplementing with other type of treatment like resection or transplantation, not for a curative intent. How do you know there is no leftover tumor in segment 7?
Yeah, we have only
You can take a biopsy or any way you can detect tumor cells in the segment 7.
But the just before the surgery, the CT did not show any activity there, except for the taste shadowing. Otherwise, no activity was seen.
That is imaging.
Yeah, it's only imaging. We don't have any biopsy or anything. Of course, there's a concern there that I agree. But the response to such small tumors are very good. That was our point of view at that point of time.
You can come with the recurrent because the report is satellitosis. If it is metastasis cells, we can come back with the recurrence in rest of the liver, right?
So we'll have to be on close follow-up with it.
Okay.
Are there any further questions?
There is a question in chat box. It seems.
Can the pancreatitis be related to paraneoplastic syndrome in HCC? I must confess that I really don't know. Does anybody else have an idea? Hello? Hello?
Yeah, we can hear you, but nobody.
I understand. I think I need to take.
So they have already looked at the triglyceridemia part and hypercalcemia. So apart from this hypercalcemia and triglyceridemia, I don't know whether any other tumor proteins can result in that sort of pancreatitis, which is very, very unlikely because that showed extensive necrotizing pancreatitis. And it's very interesting with just antibiotic with a 6 weeks period, it's completely resolved and patient became better for a major, significantly better for a major surgery like this. So it's very interesting.
One possibility is it could have been an end communication rather than an infection. It might have been breaking into some of the viscera, maybe stomach or colon, and it might have got resolved by itself. But usually, even in that situation, they get, especially if it ruptures into the colon, they usually have a very bad cause. That's usually we have seen, as Ramendran said.
Yeah, right now we are having another. It's not a similar case, but it's slightly different case. So it's a case of cholangio, attempted stenting, and subsequently had a duodenal perforation and necrotizing pancreatitis. So we are struggling. So major issues. So
Okay.
luckily,
We had one patient who presented with mild acute pancreatitis. That a patient who had a colorectal liver metastasis. And initially we thought he had some biliary sludge. I think initially we thought it's related to biliary sludge. During ERCP, they found some membranous thing in the CBD. They took it for a biopsy and it was indeed a tumor emboli. So that's why I asked. I have seen one patient like that. But it was a mild acute pancreatitis. It was not a severe pancreatitis.
Ashna, one more thing, just for residents. Did you do any diagnostic or staging laparoscopy before surgery?
For this patient, no,
Yes.
sir.
Especially these sort of cases, it's probably better to put a scope and see the residual, because it was a multicentric HCC. You have done the TACE, AFP is on the lower side, but still, it's probably better to put a scope and see the FLR as well as the tumor side to see whether there is any surface mets. You had a suspicion of tumor rupture also. So it can sometimes result in peritoneal dissemination.
Yes, sir.
Okay, if there are no further questions, let me congratulate Ashna on presenting it really well, and even more congratulations are due because she handled the questions with skill and aplomb. Congratulations, Ashna. Handing back to Pidambar.
Thank you. I'm going to share my screen again.
Not coming up. Yes.
Yeah. So this is the question, the answer, the complete answer was given by Prakash sir. It's a duodenal stent and double biliary stent. Actually, this patient presented with hilar cholangiocarcinoma. Initially, patient underwent double pictal plastic stent. Later, when we planned for a SEMS, the patient had developed a duodenal obstruction. So anteroduodenal stent was placed, and then stent was exchanged to biliary stent was placed through the anteroduodenal stent. SEMS was placed, and many answers was there that biliary stent and duodenal stent. The complete answer was given by Prakash sir. That is duodenal stent and double biliary stent. Thank you, sir.
Where is the second biliary stent? I couldn't see. I wrote only
They're
biliary
almost on the
stent.
border of the spine, sir.
Border of the spine. Can you show it in with the marker?
Yeah, this is the second biliary stent, sir.
Oh, my vision is poor.
This is the anteroduodenal stent. This is the first biliary stent, and the second biliary stent is put into the left system.
So Pidambaran, why it is a smaller one, the second one on the left side?
Actually, just put
So
probably.
put a,
I don't know
usually
actually. It is put through this stent.
Yeah, can I ask a question? Does that actually extend into the duodenum, or is it only across obstruction in the bile duct? That is my thought.
It is extending into duodenum. I'll show the images.
Yeah.
One of them I agree is extending.
Yeah,
out. It's the second
this
one
is-
extending out.
Second one is not extending into the duodenum. Second one is
Exactly.
extending into the
Okay,
first
right.
first stent.
Okay.
Second
So
one is
why
draining into the
the
first.
longer one was put on the right side?
I don't know, sir.
Okay,
This was
okay,
put by
okay,
put by our medical gastroenterologist.
okay.
So actually, I was looking for a question for a quiz, and I was searching, and
You should
Very interesting
probably
case. Very interesting.
you should value your medical gastroenterologist. Make sure that you keep extremely skilled chat.
So this is not. Sorry, this is a.
sir.
Hello.
Hello,
So,
yeah.
So patient initially presented with.
Hello. Hello, who is?
Pidambaran,
You
we
are
can
audible.
hear
You are
What is
audible,
your-
Pidambaran. Yeah.
I am audible. Somebody is asking me. No, I think 1 minute. 1 minute.
Hello.
Yeah.
So this case, very interesting case. It's a hyalocholangiocarcinoma. So the initial diagnosis was something like a type 4 stricture, inoperable, or because of performance status you decided for.
No. This patient has a hyalocholangiocarcinoma with a metastatic node in the ampullary region, which is causing double obstruction. One is the obstruction of the ampulla, and the other is the hyla.
Okay. So
That was the reason why. Yeah, that was the reason why double pectoral stent was put initially, and then later, when he came back, tried to change the metal stent, it was already gastric outlet obstruction. Then this endodural stent was placed. After 2 weeks, again the other stent was placed through the stent.
So what was the interval between these two stents, the duodenum and the biliary?
2 weeks.
2 weeks. Okay.
Yeah. The first plastic stent to the duodenal stent was around 2 months. After that, duodenal stent, then 2 weeks, and then put the biliary stent. After 2 weeks, by the time the
So
duodenal
initially
stent
place the duodenal stent and then subsequently place the
biliary stent.
Oh, that's very interesting. That's very difficult, no?
Yeah,
After placing the duodenal. Usually it will be the other way.
Yeah, but initial plastic at that time there was no duodenal obstruction.
Okay.
When initial ERCP, while putting the plastic stent, there was no duodenal obstruction. When he was planned for a metal stent, we were not able to do that. So put an anteroduodenal stent, waited for 2 weeks. After that, stent exchange from plastic to metal stent.
So again, endoscopically you place the duodenal, the bile duct stents.
Yeah.
Interesting. Usually it will be very difficult when you are doing a side endoscopy. You need to retroflux and then through the stent you have to do that.
Yeah.
Even if you manage to go across, expanding the stent through the mesh of the original duodenal stent becomes very difficult. I'm wondering how he did that.
Actually, the opening of the stent was made, initial balloon dilatation, the stent opening was separated and then changed.
Okay, right.
So, is there anything to discuss further?
I think we can conclude.
Okay. Joshi is there? Dr. Joshi?
Not yet.
So, so we had yet another excellent academic session. Dr. Ashna, you have presented it very well, discussed it also very well. Thank you, Ashna and Dr. Prakash, for this brilliant case. Thank you, Dr. Unni, for the fabulous moderation, and we really enjoyed the discussion. Thank you, Pidambaran, for the wonderful picture and all the technical Zoom and arrangements. Thank you all the participants. So next month we will again come with another interesting case. Till then, goodbye.